agree with some of what Mark and others were saying. It's really important to be very clear about what one means when one uses the term, and not assume that everyone understands what it means. But it sometimes is a really important kind of therapy for the most difficult cases. And I guess so yeah. So
you can just say next slide, and I'll do it.
All right, previous slide. Do you want me to do it? I can do it too, I guess. So I don't take any money from private industry. I would just add that the way I think of palliative sedation in palliative care is it's a sort of a similar to the way I thought about cardiopulmonary resuscitation when I was working in the ICU. It's, what you do if worst comes to worst. So when I used to go on duty in the ICU when I was an internal medicine resident, when I was driving to the hospital, every time I was on duty in the ICU, I would review in my head the cardiopulmonary resuscitation protocols, because I wanted to know I wanted to be able to do it really quickly when it happened. And I felt that that's what you do when worst comes to worst, somebody arrests. In palliative care, this is also what I think we need to be able to, we need to know how to do if worst comes to worst. Very rarely needed if we have the basic tools of palliative care and we know how to apply them. But in the worst, most difficult situations, that's what we need to know how to do. So that's how I think of palliative sedation. Next slide. And I would urge you to distinguish at least between three kinds of palliative sedation, as does the American Academy for Hospice and Palliative Medicine in a paper that they wrote on this. Ordinary sedation is the sedation that occurs with standard palliative care. A lot of the medicines that we use are sedating. Opioids, benzodiazepines, neuroleptics, all can be sedating. And sometimes the sedation is welcome. So for example, this patient didn't sleep well and was getting nortriptyline. Nortriptyline, by the way, there are other tricyclics which are even more sedating than nortriptyline. But in any case, ordinary sedation is the side effect, whether desired or not, from standard palliative care. Next is proportionate palliative sedation. And the idea there is that sometimes sedation is intended, and I'm going to insist a lot in the next few minutes on the idea of intention. Some degree of sedation is intended as a way to achieve comfort, but the effort is only to sedate to the point where the patient is comfortable and without causing unconsciousness. So it seems like in this case, maybe this patient was receiving proportionate palliative sedation. And then what I've written about more and in various places is palliative sedation to unconsciousness, where the intention is to sedate someone to unconsciousness, a dying patient whose severe refractory distress cannot be relieved adequately without sedation despite aggressive efforts. Now, that's my definition of palliative sedation to unconsciousness. And this definition I take very seriously. It has to be a dying patient. it has to be someone who has severe distress that is truly refractory, that distress that has not been adequately relieved despite aggressive efforts to use standard palliative medicines like opioids and benzodiazepines and neuroleptics. And that is really quite rare. In our hospital, our 1,000-bed hospital here in Boston, where we're a referral center for the most complicated, difficult cases, we use it a few times a year. In the first few years, when I first wrote a protocol for it, I think we did a survey of about the first 12 to 15 cases over about 3 years. So 4, 5, 6 cases a year, maybe fewer, maybe a few more, but that's among hundreds, probably even over 1,000 patients per year. So it's really very rare that we need it. That's but it's mentioned much more often. And one of the worries that I have is that there may be people who ask for it prematurely. And I can remember very well walking onto one of the floors in the hospital and having one of the clinicians on the floor say, "Oh yeah, this patient, I think this patient needs palliative sedation. The pain is really severe." And I discovered that the patient did have pain, and it had 2 doses of morphine, 2 milligrams IV, and it wasn't effective. And they were asking, literally, I'm not making this up, and there was someone asking for palliative sedation. The thing was partly because the family was very upset, but that's not when you think of palliative sedation. So one has to be, I think, careful about when to start talking about it. I urge everyone never to use the term terminal sedation, because that connotes euthanasia. And palliative sedation to me is radically different from euthanasia, although there's some people who question that. Which symptoms may actually become refractory? I think it could be any symptom that causes severe suffering and cannot be adequately relieved. So it could be pain, and in my experience, it's been all of these: pain, dyspnea, nausea, myoclonus, seizure, agitation, agitated delirium, even severe anxiety, and it could be others. So it's not necessarily just pain. Next slide, please. A lot of patients fear terminal distress. And so it's sometimes, I find, useful to mention that if worst comes to worst, we can make you sleep. When talking to a patient who's very worried about refractory suffering, maybe someone who's had pain or other symptoms in the past that weren't well controlled, and they're very afraid of that. And I'm trying to say, look, this is what we do. We're experienced in palliative care. But if they're still really worried, or if you're worried because the symptoms do seem difficult to control, just talking about palliative sedation often can make people feel much less worried. And so I talk about it much more often than I use it. I just mentioned that worst comes to worst, I can make you sleep, and people feel, I think, very relieved and reassured about that. No, way too fast there, Mark. How long do we have actually? Is it 10 more minutes or what?
10 to 12 minutes.
Okay, all right. So still sticking with the definition, palliative sedation is intended only to relieve intractable distress, not to hasten death. Now, it's recognized that death can be hastened sometimes unintentionally, but foreseeably, just when we're giving meds at the end of life in very frail patients. In fact, I often think that patients who are very near death die from being repositioned or from just one of the regular scheduled doses of opioid. How many times I've been told that the nurses were repositioning the patient and the patient died, and a nurse is maybe worried that she caused it, and it's just that the patient was very close to death and passed away. It happened to be when there was that little movement that was enough to cause the heart to arrest in someone who was very close to death. So the intention, and again, I'm emphasizing the intention, must only be to relieve intractable distress, never to hasten death. And very importantly, it should only be used for a proportionally grave reason, no pun intended. We don't induce sleep or induce deep sedation for something that's not very, very serious. Only for relieving the severe refractory distress of a dying patient who wants to be comfortable. That's a proportionally serious or grave reason. Now, there are some data on how long patients with such severe distress live if they get sedated and if they don't. And the available data looks like they don't live, neither group lives longer than the other. It's just one group is more comfortable than the other. Next slide, please. So this, I've been hinting at what's called the principle of double effect. And I think this is one of the ethical principles that I think is very useful for any palliative care toolkit. It can help palliative care providers to think through what they're doing. So I think it's really useful both to feel confident, if we use this principle, to feel confident that we're doing the right thing, and also to be able to explain it to someone who is wondering why we're doing what we're doing. We're using medications like we're using them. So this is a really old principle. It's often traced back to Thomas Aquinas. And it's for, the principle of double effect is for deciding what to do when anything that one does risks a bad effect. It's not only, in fact, it wasn't originally applied in medicine. It's applied, for example, in politics. So if you're the queen and you're a pacifist, you don't believe in killing, but another country invades your country, what do? Do you fight back and violate your principles of pacifism? Do you not fight back and then your people are killed? So here's a situation where whatever you do risks a bad effect. That's where the principle of double effect can be applied. When applied to end-of-life care, and again, this can be for patients with any religion, from any religion, what it means is that if desired by a terminally ill patient or a surrogate, medicines intended to provide relief from severe pain or other symptoms may be used even at the risk of foreseen but unintended side effects. So for example, high-dose opioids can be given to relieve severe pain or dyspnea, even at the risk of foreseeable but unintended sedation or hypotension or respiratory depression. Next slide. When this principle is applied in palliative sedation, the sedation is intended. The unintended, though foreseeable side effects might be hypotension, respiratory depression, and hastening of death. Now, one of the really important issues if you're going to do palliative sedation is documentation. And this is not only important, I think, to show everyone what you're doing. I find it really important for myself to help me think through what I'm doing. And this can all be done on one piece of paper. And I'm old enough, so I actually use this object, which is called a pen. I know that young people like Dr. Stoltenberg don't use these anymore, but I use a pad of paper like this and a pen. And Mark, I'm sure you can do this online, but I will write down, I'll make a little chart. So indication for palliative sedation. Why am I doing this? pain non-responsive to very high doses of opioids and adjuvants, for example, or in this case, seizure or choreiform movements with crying out, not responding to opioids, neuroleptics, and benzodiazepines, for example. Then what regimen do I use? So I say what medicine I used in what dose. Then the next column is how did the patient respond? No improvement, for example, after 15 minutes. And then how I responded again. And I want to get back to something that Dr. Prasad said, which I think is really important and really excellent. In patients who are having severe distress, like this patient or any patient where you're beginning to think about palliative sedation, what it usually requires to find out if the symptom is really refractory is exactly what Dr. Prasad said. Standing at the bedside and pushing meds every 15 minutes or every 30 minutes and titrating. And if that dose didn't work, whether using opioids or benzos or whatever you're using tailored to the specific symptom, keep at it. If that dose doesn't work, double it. If that doesn't work, double it again. And it's labor intensive, but that's how you find out if a symptom is refractory or not. And if you keep a table of what you're doing, that helps you think it through. You know exactly what you've given so far. You know exactly why you gave it. And anybody who questions you, you can show that. So I'd urge you to do that. It doesn't take a lot of time. You can just make a table in 15 seconds and jot this stuff down. Next slide, please. And I'll finish up. The four conditions for the principle of double effect are usually described as these. The act must be good or at least morally neutral. And this is just giving a medicine, so there's nothing wrong with that. Only the good effect, such as relief of suffering, not the bad effect, death, can be intended. So intention is really crucial here. The bad effect may not be the means to the good effect. You can't say, well, I'll give so much medicine that the patient dies and then the patient's comfortable. No, that's violating the principle. And then what I said before, the rule of proportionality, namely the potential benefit of the good effect must outweigh the potential burden of the bad effect. Next slide. I think I'm almost done here. I'll just say that this idea was supported in a U.S. Supreme Court decision 20 some years ago. Next slide. The indications I've really mentioned already. It has to be there has to be a severe chronic life-threatening illness, and the symptoms must truly be refractory to standard medicines, opioids, benzodiazepines, neuroleptics. Next slide. Prerequisites for palliative sedation to unconsciousness, PSU, comfort needs to be the goal of care. There needs to be an order. These are the rules in our hospital, but it's also, recommendations that I've made elsewhere. There needs to be an order to withhold life-sustaining treatments like cardiopulmonary resuscitation and endotracheal intubation. The patient's attending physician has to be in agreement with it. And ideally, everybody on the team should be informed about it and given a chance to understand what it is, and then to decide if they might have a conscientious objection to not participate. Next slide. Which I've found very rare. Once or twice when I've been called to do palliative sedation, I've had someone come to me and say, I can't do that, that's unacceptable, that's euthanasia. And then I explain it, and I've never actually had someone conscientiously object. I remember there was a respiratory technician who conscientiously objected initially, and I explained it, and he said, oh, well, I can participate in that. So there's a lot of misunderstanding, which is again why the definition is so important. Just a word about the medicines that are used. Um, Midazolam, like any benzodiazepine, is often written about as useful for palliative sedation. I think that's fine to use, certainly for proportional sedation, although I always worry with benzodiazepines that they can cause paradoxical agitation. In this case, the patient was already getting haloperidol. I don't know how much, but as long as there are moderate or high doses of haloperidol being used or other neuroleptics, it's safer to give benzodiazepines with less risk of paradoxical agitation. So the two of them together often provide adequate sedation, proportionate sedation. For palliative sedation to unconsciousness, I tend to use a more reliable sleep-inducing agent like propofol or thiopental or pentobarbital. I think that, is there another slide? Oh, the last slide is just some special circumstances for using palliative sedation. One is so-called existential suffering, and there's a lot of debate about that, and it's a very complicated topic, but I think that intensive psychosocial supports should be have to be applied before thinking about palliative sedation for existential distress. Respite sedation is when unconsciousness is induced for a short period, usually hours to a couple of days, for patients with very severe distress, suffering of one kind or another, often it's pain, in the hope that just getting some rest, they'll somehow be better. And there's case reports of people whose pain is just better after respite sedation for no reason that can be explained. And finally, when discontinuing mechanical ventilation, some patients just don't want to be awake for that. Others do, but some don't. And I think it's not unreasonable to keep patients sedated when removing mechanical ventilation with the expectation that death will occur. So that's a very, very brief review of a complex topic. Oh, concluding thoughts. Palliative sedation to unconsciousness is rarely needed, but it's good to have in your toolbox for those extreme cases when there's a dying patient whose goal of care is comfort and whose suffering is truly refractory. It can be very comforting for family to see the patient, as in this case, to be looking calm and sleeping for their last hours or days. That can be incredibly important for the rest of the family's lives to have seen the patient at peace. But it needs to be done very carefully with strict attention to medical and ethical guidelines.